Now, I will invite Dr. Navneet Teshniwas. He is from Solapur, an excellent phaco surgeon and teacher. He has 4 books on phacoemulsification. He is just going to demonstrate us and teach us if the capsule is running away while you are doing the rexis, how you can bring the capsule inside. So, Dr. Navneet Teshniwas, please.
Good morning, respected Lane sir, Ragini madam. First, I take this chance and opportunity to thanks Dr. Lane sir to incorporate me for this beautiful instruction course. The topic we have seen the hard cataract, mature cataract. Then the other situation which is commonly occurring is the capsulorhexis runaway. We have to proceed with the phaco. We have to see this presentation with the 3 parts. Why the capsulorhexis is going to be run away in a normal cases also. It may be due to surgeon, it may be due to assistant, it may be due to patient. These 3 situations. Then second, what are the instrumentations needed to manage this runaway capsulorhexis? And still when you manage, you should know the certain principle how to tackle, how to do the phaco after that. So this is the very slow movement. See, sometimes slow movement also the capsulorhexis run away. So in first book I have written that one chapter, 2-3 pages, what should be the speed of capsulorhexis at certain points. And then when this is the direction of capsulorhexis, it is difficult. Now you have to see simple air bubble. One small tiny air bubble, the capsulorhexis run away. So preparation of the capsulorhexis, the anterior chamber should be 100% devoid of any air bubble. You should see the clear-cut visualization, and these are the some of the instruments which we are used to 10 years before. The venous scissors, still these are the important. Now if you are having the micro rhexis forceps, micro scissor, that is the best. Sometime now here you can see, suddenly my assistant had pushed the water and patient moved and the capsulorhexis run away. It's a very simple situation, but the capsulorhexis run away, how to proceed? You can take the nick at the other place. Last slide we have seen of the madam that it was just rhexis run away. And how to proceed? So take at the other side and you can proceed. There are certain points when I am doing from a 12 o'clock, if it is 6 o'clock and 12 o'clock, it is difficult. If it is a sideway capsulorhexis run away, you can manage because the pressure of the phaco tip is not directly on the zonules. That's a very important. So site of running away of the capsulorhexis is very important. Here the rhexis run away. I am going no hydro. This is the Teshniwas pre-chopper to divide the nucleus. What is the intention here is that there should not be direct pressure on the zonules. That's the very important for these 2 manipulation. Very slow uplifting. As we have seen in Ragini madam presentation, all the nucleus management in a supracapsular plane. That is very important because bag is weak. So you have to lift the nucleus out of the bag to preserve the bag, not to give pressure on the zonules. That's the main principle here. Then go for the other nuclear half piece and lift it out. These slow movements are very important. Otherwise also hold and lift of the nucleus should be very slow in a routine practice also. In this specific, there should not be any stretch on bag or zonules. That is the thing we have to keep it in mind. Now, I have just mentioned that microrhexis forceps is important, that we have to use in our day-to-day practice also. We are having the microrhexis forceps. We have started doing, and here overconfidence and maybe the speed. See, that's the sub-incisional running away is very common. What we have to keep it in mind, that formation of the anterior chamber is really good throughout the procedure. If it is getting shallow, you should not be overconfident that, okay, I will manage, because all the time we are in a hurry to do that. And this is the typical point where the surgeon mind plays and the capsulorhexis run away. Putting the viscoelastics over the flap, not stretching the capsule unnecessarily. These are the very, very important points. This is the micro scissor trying to cut the capsule, because that is the only site from where we can go. This we can do with the venous scissor also. This is very important. Putting the viscoelastics, not giving any stretch, not giving any pressure. We have managed actually you have to do very small tiny rhexis, but I thought that we can manage. And while removing the debulking the pressure in the bag, this is the actually adequate rhexis, but I thought that we will little bit increase. That was my mistake. So although you are having the excellent instrument with your hand and say, otherwise I would have managed with that small rhexis. It was not very small, it was 4 to 4.5. But this is what we think at that time, and suddenly it has run away. Then you have to cut with the micro scissor. These are the very excellent, and again it is a sideway. So you can directly start with the stop and chop technique. Again the division. There is no pressure. Lift it out. Supracapsular plane. This is again I am emphasizing that you should not do many activities in the back, many procedure in the back. Bring it out. And as the sir has mentioned in the hard cataract, role of viscoelastic is very important. Dispersive viscoelastic. If you protect your endothelium, then it will be no damage to the cornea. Coaxial irrigation aspiration I am using. Bimanual is a choice in such situation which maintain the architecture. And before coming out, you can put the viscoelastic. That is another very important. Rhexis run away, but you can see, you can feel that rhexis and all that, so that you can put the whatever the IOL you are having, whatever you have decided. This is the again one question which I have asked to the sir in hard cataract. When you have to ship the case to the SICS, so many times if you are not having the best machines which works nicely with the energy, vacuum and flow rate, no need to do the aggressive things that you have to remove your ego. Just I am doing with the limbal incision many cases of mature cataract, so that I can convert the case very easily, and it is like just a routine SICS. What I have decided before, I thought to do phaco, then I have to convert, and in a very simple way, simple technique, just shift to the SICS and manage the capsule, because this is what we have to keep it in mind. Many doctors I have seen, they are excellent in phaco, but they don't have the great principle of the SICS, but it is a must. SICS is a more important surgery. As the sir has also mentioned, that is important. You cannot leave the case like that and then convert the case, and then you can put the, choice of my lens is 3-piece PMMA IOL. That will giving the excellent, there is no pressure on the zonules. It is a more flexible, and this is the way you can manage the things. So capsulorhexis runaway is the thing can happen with any surgeon. You have to be ready with the instruments and think of any time conversion. That's the final take home message. Thank you. Thank you for your